All right. Well, good afternoon, and thank you for joining us today. We have, we welcome our applicants joining us through Zoom. We have the great opportunity to have Dr. Jana Zielonka, one of our third-year fellows, present her work today, and also talk about a topic that she's really passionate about, and it's been both her clinical interest and also her research interest. Wanted to introduce her. She is a resident from our program, and she's been an excellent fellow here. She has been able to participate in multiple projects here with different people in the section. Just to name a couple, while she was a resident, she worked with Dr. Clemente Brito and was able to have her work published in ERJ. And she's been a really motivated researcher in transcriptomics of scleroderma, and her work has been pretty enlightening. And last week, just to give you an idea, she was presenting her work on skin transcriptomes linking severity of skin involvement and lung function impairment in systemic sclerosis to a big audience at ERS in Milan. So, this is not as big as Milan, that group, but we're really happy to have you here and hear what you want to tell us about novel therapeutic targets in systemic sclerosis related ILD.
Okay, great. Thank you for that introduction. I'd like to welcome everybody. I'm really excited to have the opportunity to give this talk today, and also an opportunity to give it in front of the applicants via Zoom. Hopefully I will meet many of you in person next year. So like Dr. Gomez said, novel therapeutic targets in systemic sclerosis related interstitial lung disease. Okay. Where's my, there he is, okay. So this is my disclosure slide over here. And then just a brief outline of what we're going to go through today. So first, we're going to talk about the definition, the epidemiology and pathophysiology of systemic sclerosis-related interstitial lung disease, then talk about current and emerging therapies, then specifically a little bit about what I've been working on, and then the future directions. Okay, so systemic sclerosis, also called scleroderma, you'll hear those words sort of used interchangeably. Scleroderma is from the Greek. It means hard skin, and it was first described in 1752 in Italy by Dr. Curzio as a condition that turns skin into wood. It is considered an orphan disease. The incidence is 10 to 50 cases per million people per year, and the prevalence is 40 to 340 million cases per million people. There's a female predominance over male, and what it is, in a sort of broad term, is dysregulation of the innate and adaptive immunity, endothelial dysfunction, inflammation, and fibrosis. Aberrant response to injury, fibrosis, or as I explained to my mom, it's just really bad wound healing. So here we go. There are different systemic sclerosis subtypes. There's limited cutaneous scleroderma, which only involves skin from distal from the elbows and the knees, and it may involve the face and the neck. And then there's diffuse cutaneous scleroderma, in which the skin involvement can become proximal to the elbows and knees. And then there's systemic sclerosis sine scleroderma, which is the absence of skin thickening, but involvement of internal organs and serologic findings. So some of the systemic sclerosis organ involvement, there's cutaneous, there's skin thickening, hardening, capillary changes of the nail bed, and digital ulcers. For vascular, something called Raynaud phenomenon and telangiectasias. Musculoskeletal, arthralgias, arthritis, and joint contractures. Gastrointestinal, big problem with a lot of patients with scleroderma, dysphagia, and GERD. And then for pulmonary, there's interstitial lung disease and pulmonary arterial hypertension. Cardiac, you can have vascular disease, arrhythmias, myocardial, pericardial inflammation, and fibrosis. Renal, there's scleroderma renal crisis, and neuromuscular, you can have myopathy and muscle atrophy. So this is just a diagram of some of the skin findings that you can see. In A, which is the top on sorry, you're right, top right. Sclerodactyly is just thickening of the skin on the fingers, and then the fingers eventually become contracted. And then in B, there's something called Raynaud phenomenon, which is vasospasm of the fingers resulting in cyanotic discoloration. So people will describe their hands as turning white and then blue with any exposure to the cold, or sometimes not even with exposure to the cold. Then there's telangiectasias, which are just dilated blood vessels. That's in picture C. And in picture D, this is capillaroscopy, which is an examination of the nail fold, and you can see just dilated capillaries under the nail fold. And then there in E is a digital ulcer. And this is important because it's going to come up in some of my research, and a lot of the treatments that I talk about is how we gauge disease severity, disease progression, is the modified Rodman skin score. It's called the MRSS. And what it is it's a quantitative, semi-quantitative method where you take 17 different cutaneous locations on a person's body, and you measure from 0 to 3 the skin thickness, 0 being no thickness and 3 being severe thickness, with a total of 51 being the highest you can get. And 51 is obviously the most severe, and 0 is not severe at all. And a lot of clinical trials use this as an outcome, which is why I bring it up here. So now to talk about systemic sclerosis related pulmonary diseases. So I'm going to briefly talk about pulmonary arterial hypertension, because this is a topic that probably deserves its own Grand Rounds month. So I'm just going to talk a little bit about it because my topic is interstitial lung disease. So, and often the two can occur together, and that's a whole other month of Grand Rounds. So the systemic sclerosis, which I'm going to call SSC from now on, because it's going to condense the time a little bit. SSC-related pulmonary arterial hypertension affects 7 to 12% of people with SSC. There's a 3-year reported mortality of 21 to 48%. It's associated with anti-centromere antibodies and possible THTO antibodies. It's associated with telangiectasias. There's a worse prognosis compared to patients with idiopathic pulmonary arterial hypertension, even when you control for similar hemodynamics. One of the algorithms to sort of screen patients with ILD, with SSC for pulmonary arterial hypertension is the DETECT algorithm. And it's a tool where you use PFTs, BNP urate, presence of anti-centromere antibody, right axis deviation on EKG, current or past telangiectasias. If you're unclear, then you go get an echo. And that's so not everybody who has scleroderma goes for a right heart cath. Okay. And now, this is what we're going to spend the majority of the time talking about, SSC-related interstitial lung disease. So 80% of patients with SSC will have findings of ILD on autopsy. 30 to 40% develop clinically significant ILD. It occurs mostly, and I say that with an asterisk, within the first 5 years of your first non-Raynaud symptom. And histopathologic and radiology features, NSIP is generally the predominant one, 17 to 80, and you can see UIP in 20 to 30. You can see others like HP, but NSIP is by far the most common. There's 40% 10-year mortality in these patients, and most common disease-specific mortality cause, which is 30%. So this graph on the left is a study from a nationwide cohort in Norway. It's 815 patients, and mortality correlated with extent of lung fibrosis. The standardized mortality rate increased from 2.2 with no fibrosis to 8 with greater than 25% fibrosis. Even SSC ILD patients with mild lung fibrosis and normal range FVC developed frequently progressive ILD and had reduced survival. Even moderate ILD progression after long duration was associated with worse outcome. So this is one of my favorite slides, and this is sort of a proposed mechanism for the way SSC ILD sort of comes about. And it's cyclical for a reason, because it's unclear where it starts, where it ends, and how much the interplay is. It could be everything all at once. It could be more of a sort of trajectory. But basically, the leading theory of the proposed mechanisms is you have a susceptible phenotype. And then you have some sort of intrinsic or extrinsic epithelial damage, which is up here. So you have tissue injury. It could be an environmental injury. It could be some kind of intrinsic injury. And then after that, you have a vascular injury. So you have endothelial activation, tissue hypoxia, and ineffective angiogenesis. after that, the immune cells come in. Influx, macrophages, monocytes, followed by your T cells, your B cells, your cytokines, IL-4, IL-5, IL-13, IL-6. That stimulates TGF-beta, which is a profibrotic factor. And that stimulates fibroblasts to become profibrotic. And they can go into all sorts of different kinds of cell types. The big one being myofibroblasts, which are a key player. And myofibroblasts produce tons of collagen, and they lay down extracellular matrix everywhere. And then it becomes dysregulated fibroblast signaling. So nothing tells the signal to shut off. So it just keeps going. One of the theories is that some of these cytokines can make your endothelial cells and your epithelial cells become mesenchymal cells. So they go from being endothelial cells and epithelial cells to mesenchymal cells. So everything just like becomes a fibroblast. They take over. And persistent just activation of fibroblasts, and then just interactions between all of the different cells and different things. So that's basically the proposed mechanism. This is just a diagram of like all the cells involved. As you can see, it involves the endothelial cells like pericytes and capillary cells. And then you can see it involves alveolar cells as well as all of your immune cells. So not to spend too much of a time on that, but I think that's a very good sort of mechanism description. And you can see here, it's sort of this initiation with this progression, with this failed resolution in the fibrotic stage. And then just some like brief mention of pathways, because I think they're important. Some of the pathways that have been implicated are activation of platelets and thrombin, activation of profibrotic growth factors such as TGF-beta, PDGF, which is platelet-derived growth factor, and VEGF, which is vascular endothelial growth factor. There's also some thought that there's activation of signaling pathways such as Notch, Hedgehog, and the Wnt beta-catenin pathway. And then there's thought also that there may be activation of the JAK-STAT pathway. And then epigenetics may also be at play with histone acetylation, DNA methylation, and microRNAs. So TGF-beta is one of the most widely studied pro-fibrotic factor, and it's crucial into turning the fibroblasts into the myofibroblasts, which can, like I said, just lay down collagen and extracellular matrix everywhere. So why not just target TGF-beta? Because it basically is everywhere. So you can't just turn off TGF-beta. They actually tried that in a study a long time ago, and it just made everyone grow a lot of skin tumors. So that didn't work. So we have to sort of look for other pathways or downstream pathways from that. Histopathology, just quickly on your right, you'll see sort of more non-specific interstitial pneumonia pattern, which is, like I said, more common. And on the left, you'll see a usual interstitial pneumonia pattern, which is less common. And imaging that reflects that too. In A, this is a high-resolution CT, which on the right is showing non-specific interstitial pneumonia changes, and on the left is showing the pattern of usual interstitial pneumonia. And also you can see here on both of these, the esophagus is patulous with an air fluid level, which is also a very common finding in these patients. Okay, so risk factors for SSc-ILD. So we know some of them, but they're not 100% and they don't hold true all the time. Males tend to develop it more than females. African Americans tend to also, although a recent analysis done, I think in 2021, they actually, for a long time thought African Americans have worse disease progression. They actually did a post hoc analysis of 2 big trials and saw that there actually was no difference in morbidity and mortality when they controlled for all sorts of variables. So that may or may not be true. Diffuse skin disease, genetic polymorphisms, there's a lot of them. A lot of them are in the HLA region. Nail fold capillary abnormalities, and then autoantibodies is a big one. So positive anti-topoisomerase 1 antibodies, we know it also as anti-SCL70, actually is a predictor of developing ILD. Not 100%, and people without it can, and people with it don't. The other ones that I'll just point out are anti-TH and TO, which are also, they're less common. They're more of a mixed connective tissue disease like overlap, and anti-PM-SCL, which is also an overlap of polymyositis. It's rare in anti-centromere antibodies. That actually portends more chance of getting pulmonary arterial hypertension. And this is just a graph just looking at the autoantibodies associations. It's a nice graph because you can see that anti-SCL70 or anti-topoisomerase is progressive interstitial lung disease correlation, and anti-THTO also. All right. And then just some candidate biomarkers. So we have CRP, IL-6. CRP is really the only one that I think is like widely used in practice. IL-6, and then there's KL6, which is Krebs von den Lugen glycoprotein 6. It's a marker of epithelial injury. We have CCL18, which is chemokine ligand 18. SPD, which is surfactant protein D. That's a colectin. It's produced by type 2 alveolar cells, and it plays a role in pulmonary immunity and reducing inflammation. And then this is my favorite, the eNose technology. So when I was in ERS, there was actually a lot of people presenting on eNose technology. And this is what I pictured the whole time. It actually turns out it's just like a little box, but this was what I was in my brain. So it's inhaled analysis of breathomics, I guess the way you pronounce it. I've never said it out loud before, breathomics. So it detects volatile organic compounds, and they could differentiate between connective tissue disease-related ILD, IPF, and healthy controls. It is not a dog. That's just a picture. It's like a computer. All right. And then imaging biomarkers. This is another thing I'm not going to spend a long time on, but I think is really, really cool. So there's radiomics now, and this is quantitative high dimension image analysis. So basically it uses quantitative data, including like the intensity, the texture, and then use statistical properties to come up with a sort of score to like define your risk of progressing to like severe ILD. And on the left side, you'll see there's a PET CT that actually can measure fibroblast activity. So those are two upcoming radiomics that look forward to learning more about. So current management guidelines, it's not entirely clear, and in different guidelines like exist in different places. This is one from the expert consensus on the management of systemic sclerosis associated interstitial lung disease, and it's out of 13 pulmonologists and 12 rheumatologists. So I'm going to just pay attention to the top two and just highlight a couple of things from it. So one of the guidelines is that we should be screening every single patient with SSC with an HRCT, with a high-res CT. And I'll get to that when we talk about some of the treatments and some of the trials. And it's unclear if every center is actually doing that. So that's one of the things. And then in the second one, treatment criteria, they suggest FVC less than 80% and any degree of ILD or symptoms, greater than 20% lung involvement on HRCT, or greater than 10% on HRCT and abnormal PFTs. Then high-risk patients with early diffuse cutaneous systemic sclerosis with evidence of mild ILD, and then worsening high-res CT with symptoms or declining of PFT. So as you can see, it's not, it's sort of very much open to like individual management and individual treatment plans. So risk stratification, and this is a really, really fast changing area about how we risk stratify these patients. So this is a very recent study from the USTAR database, which is a large database over in Europe that has a lot of systemic sclerosis patients. And what they had was 826 ILD patients, SSC ILD patients, and then only 27% showed progressive ILD over the first year. And then over 5 years, 23 to 27% showed progression annually. There's a very heterogeneous and variable disease course. 58% had slow decline with actual periods of plateau and improvement followed by decline. And only 8% had rapid decline in FVC. And this is important because a lot of times we think we should treat when we see it getting worse. But when we see it getting worse, maybe it's too late, or maybe we're not capturing it when it's getting worse because it doesn't progress in a uniform way. So this is current and emerging therapies. So this is just a list. I'm going to go through some of these in a little bit more detail. These are the current treatments that we commonly use. There are some that we use less commonly. To point out, the only two that are FDA approved in the United States are tocilizumab and nintedanib. So going in order of the trials. So this is the first one. This is in 2006. And what they did was compared cyclophosphamide to placebo in patients with SSC ILD. And cyclophosphamide, for people, is a nitrogen mustard drug or an alkylating agent that decreases DNA synthesis. It has immunosuppressive effects and selectivity for T cells. So it can regulate, it has immunomodulatory effects on regulatory T cells. All right, so in this trial, there was 158 patients, and what they saw was a small benefit in FVC at 12 months in the cyclophosphamide group. What they did notice was there was 12 months of treatment and 12 months off of treatment, that most of the treatment effects were lost after they were off the treatment for 12 months. So they did not sustain after they were off treatment. And then was significant adverse effects, leukopenia, neutropenia, and hematuria. So that led to the SLS2, Scleroderma Lung Study 2 trial. And what this did was compare mycophenolate with cyclophosphamide. And mycophenolate is an inhibitor of inosine monophosphate dehydrogenase, which impairs T cell and B cell proliferation. So they compared mycophenolate for 24 months versus cyclophosphamide for 12 months, followed with 12 months of placebo. And what they saw was improvements in FVC, radiographic fibrosis, dyspnea, and skin findings. And this was in both groups. But what they also observed was there's no difference between mycophenolate and cyclophosphamide, and mycophenolate was better tolerated. So now currently, for the most part, first-line treatment in SSc-ILD, both limited and diffuse. All right, this brings us to 2019. So nintedanib for systemic sclerosis-associated interstitial lung disease. So nintedanib, OFEV, tyrosine kinase receptor inhibitor. It inhibits PDGF, FGF, which is fibroblast growth factor, and VEGF. And what they saw was with patients were included with their FVC was over 40% and their DLCO was between 30 and 89. So their rate of decline, FVC decline, was lower in the OFEV group at 52 weeks. And you can see it was negative 52.4 milliliters a year versus 93.3 milliliters a year, which was a 44% reduction. I will note that 16% in treatment group discontinued due to adverse effects, only 9% in the control group, and they did see a sustained benefit at 100 weeks. There have been several post-hoc analysis that show the patients who were also receiving MMF at the time had the smallest decline in FVC. All right, the FASCINATE study. This is tocilizumab. So this was a phase 2 study, and what they did was patients with early diffuse cutaneous scleroderma, less than 5 years of duration, and evidence of activity, and they used inflammatory markers or worsening skin. And what they gave was subcutaneous tocilizumab weekly versus placebo. And they noticed that the primary outcome, which was MRSS, was not observed. They did notice that there was stabilization of FVC predicted at 48 weeks, but no difference in patient-reported outcomes in the tocilizumab group. Now, treatment and placebo groups had mild lung function impairment with FVC 80 to 82% respectively, and DLCO 73 and 74% respectively. So not overly bad lung data there. So that prompted, we didn't get a skin signal. Let's do another trial. This was phase 3. This is 2020 focused, which then they looked at tocilizumab again, found that the primary outcome of skin score was not met, but they did again see FVC stabilization at 48 weeks. This time they measured in 0.1% versus 6.4% in the TOSI group. No reported differences in the patient-reported outcomes except for fatigue. It was well tolerated. And they have done some post-hoc analysis that have showed that the FVC improvement was consistent across all different severities of ILD by HRCT, with the note that they still did have that same inclusion criteria of the FVC and the DLCO, but they did notice that even people with evidence of severe fibrosis on HRCT showed the same FVC improvement with tocilizumab. All right, so then we're almost done with the trials. This is the DESIRES trial, and this is a recent one, and this is rituximab. And rituximab is a monoclonal anti-CD20 medication, and it depletes peripheral B cells through antibody-dependent cell-mediated cytotoxicity. And what they saw in rituximab weekly for 4 weeks versus placebo, there was improved MRSS at 24 weeks. And subgroup analysis actually showed at 24 weeks, FVC predicted improve as well in the rituximab group. And you can see there, those are the percentages. So, and this is the latest trial, which was done this year. It's called the RECITAL. And this was actually in all patients with connective tissue disease associated interstitial lung disease, but this was also rituximab versus cyclophosphamide. So FVC was improved in both groups, and so was health-related quality of life, but there were fewer adverse events in rituximab group and lower exposure to corticosteroids in the rituximab group. And rituximab is actually FDA approved. I guess it's not FDA. What's the equivalent in Japan? So, all right. Novel therapies. This is kind of fun. So these are like some of the things that are in the pipeline, some in phase 2 studies, some in phase 3 studies. And this is also my chance to butcher all of these names. So Rumilumab. All right. It's a humanized IgG4 antibody that neutralizes IL-4 and IL-13. And it's a phase 2 RCT that showed a trend towards improvement in FVC. So these are all immunomodulators. And then abatacept is a recombinant fusion protein that inhibits T cell activation. And in a small phase 2 clinical trial, they saw a trend toward skin improvement and significant improvement in health, self-reported health assessment. And just then there was tofacitinib. This is a JAK inhibitor. It's actually a non-selective JAK inhibitor. There's a phase 1, phase 2 trial that saw a trend towards improvement in skin. And there's one of itacitinib, which is a JAK1 inhibitor. And that trial is underway. And that's a very selective JAK1 inhibitor. So these are kind of immunomodulatory therapies in the pipeline. Some antifibrotics in the pipeline. Belumosudil. Okay, so this is a Rho-ROCK inhibition, and there are 2 trials underway, and this works in the Rho-ROCK sort of autotaxin LPA pathway, which I didn't know about until I started learning about this, but that, downstream can lead to fibrosis. So that first one is underway. There are 2 trials underway, and then there's ziritaxestat, which is an autotaxin inhibitor, which showed in a phase 2 trial significant improvement in MRSS and no change in FVC. And then there is the scleroderma 3 trial, which is pirfenidone, which we know from interstitial idiopathic pulmonary fibrosis versus placebo as an add-on to MMF. And that study concluded in June of 2022. All right. And then just other medication classes. There's riociguat, which we know from pulmonary arterial hypertension, showed us, this is an interstitial lung disease though, showed a trend towards improved skin and FVC. And then lenabasum is, I think how you pronounce it, it's a synthetic cannabinoid receptor 2 agonist. So they did phase 2 and phase 3 studies with a possible trend towards improvement. It's thought to reduce inflammation. All right. And then some just novel therapies, which I'll go through pretty quickly, are cell-based therapies. So there's mesenchymal stromal cell therapy. We use CAR-T and CAR-T. CAR-T is chimeric antigen receptor T cell therapy, and CAR-T is chimeric autoantibody receptor T cell therapy. And then there's autologous hematopoietic stem cell transplant. And they have 3 RCTs that actually demonstrated improvement in event-free survival and overall survival when compared to cyclophosphamide. Not a lot of centers do this, and the initial period after the stem cell transplant is you're at a higher risk of mortality, but in the long run, it showed a longer overall survival if you get through that little part. So those are the novel cell-based, and of course, there's lung transplantation, which I didn't include just for the sake of time. And this is a treatment algorithm just recently published in the American College of Rheumatology, 2023. And it's for the treatment of ILD in patients with systemic autoimmune rheumatic disease, or SARD. And I'm not going to go through this. It's really kind of good to refer to. But what I will point out was that in green, these are all conditional recommendations. So none of these are strong recommendations. There is, however, a red hard stop, strong recommendation against corticosteroids for the treatment of systemic sclerosis because of the risk of scleroderma renal crisis. So this shows this is the initial, this is for people with progression, and then this is rapidly progressive ILD. And it's basically the treatments that we went through. Okay, so in summary, the development of interstitial lung disease in scleroderma patients is common. It's the most common disease-specific mortality. The course of SSc-ILD is highly variable, and it's difficult to predict who will progress and the rate of progression. There's no validated biomarkers. PFTs are neither sensitive or specific, and there's significant radiation exposure with repeated HRCTs. So given heterogeneity, it's difficult to risk stratify. And then current treatments, as I pointed out, show variable efficacy, and side effects are often undesirable and may limit the use. So there is an urgent need to develop better biomarkers and classification methods for SSc-ILD, which leads to our research that we're doing here. So the study that I've been working on for now a year and a half is to predict which patients will develop clinically significant ILD using a cutaneous signature. So the hypothesis is that the non-invasive skin transcriptome, which can be easily obtained by a skin biopsy in scleroderma, can function as an intermediate phenotype to study the development of lung function impairment in scleroderma. So the study aims are to determine the clinical associations between a cutaneous signature in scleroderma and scleroderma-related lung disease, and then determine specific pathway enrichment of this cutaneous signature in the scleroderma lung, and then to determine the longitudinal performance of this cutaneous signature with lung function decline. So to start, I've used a publicly available database and found this study, which was skin gene expression correlates of severity of interstitial lung disease and systemic sclerosis, and it was in 2013. And this was a study that used microarray data from the skin of 59 patients with SSC. They were originally enrolled in 2 clinical trials, and they had the microarray information from the skin biopsies, as well as phenotypic data, including sex, immunosuppression, race, antibody profiles, the MRSS, the forced vital capacity, and the DLCO. So using this, expanding on what they had, we implemented a method called weighted gene correlation network analysis. And what WGCNA is, it's a method to identify clusters of highly correlated genes or modules or networks that can be correlated to one another as well as to external features. So instead of just taking the 20,000 microexpression array data that you have as individual genes, you group them together as clusters, and then you can compare them to external phenotypic data, as well as compare them to each other, compare them across cohorts, and compare them across time. This is just a schematic sort of detailing what that overall sort of pathway looks like. I'm not going to go through that though. So what we found after doing the weighted gene correlation network analysis on this microarray data from this publicly available data set was 31 modules that were associated with skin score. And then after that, using only significant ones, we found that 12 modules were significantly correlated with skin score. 7 were positive and 5 were negative. So I'm going to orient you to this slide a little bit. On the left, we have the names of the modules. They're just named colors. They don't really mean anything. And on the bottom, we have the phenotypic data. Inside the squares, we have on the top, you can't really see it, but it's the correlation coefficient, and underneath it is the p-value. And red is a positive correlation and green is a negative correlation. So what I did here was just highlight what we were looking at. So in total skin score, you can see 7 were correlated positively with MRSS, means higher skin score and more positive correlation, and 5 were negative. And then of those 12, 7 also correlated with lung function. And I highlighted those. 5 were negative, and that's in the DLCO percent predicted. And 5 were negative and 2 were positive. All right, after that, we performed something called KEGG pathway analysis. And just a little introduction to pathway analysis. It basically is a way of linking our genomes to biological systems. It compiles all of the public data that we have and represents our knowledge of molecular interactions, reactions, relationships, including metabolism, genetic information, environmental information, cellular processes, organ systems, human diseases, and drug developments. So I'm going to give this, I'll show you a little bit more detailed what we found here. We're in the modules that were significant for both lung, DLCO, and for MRSS. We found enrichment in pathways that involved chemokine signaling, cytokine interactions, extracellular matrix interactions, and focal adhesion. From that, we then clustered all of these patients into 2 different groups. So using the data still from this publicly available data set, we performed hierarchical clustering and found 2 distinct groups that clustered together. There was the group over here, blue with less severe disease and green is more severe disease. And this line on the top is just increasing MRSS score. And as you can see by this heat map, there's a big difference between the patients, the gene expression orange being more expression and purple being less expression, more expression in the patients with more severe disease. And I'm just going to highlight not all of these genes, but some of them because I think they're interesting. There's collagen, COL5A2, COL5A1, not surprising. There's TGF-beta3. There's the CTSZ, which is a cathepsin, and cathepsins have been implicated in a lot of pulmonary diseases, specifically IPF. And there's a signal for CD14, which is a macrophage. Further, this is the same clustering. Now, comparing these to MRSS and certain lung function, we see that group 1 had a lower MRSS score. So this is group 1, lower total skin score. They also had higher DLCOs and higher FVC. So lower total skin score, less severe disease, better lung function, higher FVC and DLCO, and p-value less than 0.05 for this. And then you can see an FVC predicted as well in group 2. You can see that the higher total skin score, more severe disease, and that's blue, more severe disease in skin, lower DLCO, and lower FVC. So future directions for what we're gonna do. All right, so next steps, we're gonna perform some more enrichment analysis on the differentially expressed genes. Then deconvolute the differentially expressed gene signature that we found in the skin with single-cell RNA sequencing from lungs with patients with SSc-ILD as well as controls, and then evaluate this longitudinal performance of this cutaneous signature as well as performance in additional cohorts and in response to various exposures. And then future aims, like big picture, identify specific transcriptomic biomarkers to allow for more precise patient stratification and identify novel therapeutic targets. So this is my thank you. I'd like to very much thank Dr. Jose Gomez, who's my mentor, who like picked me up when I was down, when I couldn't figure out how to load RStudio, and just believed in me and is a great mentor. And as well as Dr. Rue, he's been very helpful as well. And as you can see, lots of other people, the Department of Pulmonary Critical Care, Dr. Kaminsky, Dr. D'Ambrosio, and Dr. Clark. And this is a picture of me and my co-fellows and I, me and my co-fellows. That's before we even started fellowship. Look how happy we are. We're still happy. We are still this happy. Yeah, happy, young, rested. We still are happy, young, and rested. And John is photoshopped in because for some reason he wasn't in this picture. All right. Any questions? That's my dog, Jacob. All right. I'm going to go back to this because I want you to look at how happy we are.
All right. Any questions from the audience? Dr. Mathey.
Jana, this is not going to be an easy question for you, but why is it that this among the collagen vascular connective tissue diseases is so hard to effectively treat when we compare with lupus, polymyositis, and others? What's the problem here? Why has this been so hard? And I know you're going after it. That's your goal.
Yeah. Yeah, that is a great question because it really is a very hard disease to treat. And pulmonary arterial hypertension have worse outcomes, connective tissue disease have worse outcomes. I think it may have something to do with the interplay of the immunity and the fibrotic systems, whereas a lot of the others don't have that fibrosis component. It may be something in the signaling of the myofibroblasts and the fibroblasts that might be there, but obviously that's what I'm hoping to figure out.
Dr. Brito.
Thank you, Jana. That was really great. I guess based on your experience from working with biomarkers before, I guess the two questions I have for you are, number one, do you see a pathway to validate this prospectively with the data that you're currently accumulating? And then do you think that there is value in combining your genomic findings with maybe some soluble markers that everybody's getting a blood draw for?
Yeah, I think that's great for both those questions are great for two reasons. One, because it like puts the element of practicality into what we're actually doing here rather than just this like skin transcriptomics. Because yeah, I do see a way that forward we could validate this and use it more often. That's to sort of answer your first question. I don't think this is the end. Obviously, this is the beginning. And there's a lot to discover. And I think if we do discover specific transcriptomic pathways, they may lead us towards certain biomarkers. You know, if they delineate, oh, this pathway, oh, this biomarker, look what happens here with this cathepsin, you know, like we could maybe target that. And as far as integrating soluble biomarkers, I think that's one, I mean, I think that's great. A lot of the studies have done that. What they do is they just, you know, they do the transcriptomic data and then we would do like a actual like in vitro or like, you know, real-time experiment to validate and, you know, maybe use like serum or other things and see how they interact based on the transcriptomic data. So I think, yeah, that's sort of the big picture.
Hi, I'm Yuli. I just joined the ILD program. Do you think the biomarkers or the genomic tests you're developing, would that tell you who is at risk for developing progression, who's at risk for developing ILD, or do you see that as something that we can monitor on like every 6 months on somebody to monitor their disease?
Yeah, I 100% hope it can like figure out who's going to progress, because like we saw, like it's just so hard to predict because somebody could be stable for a while or they could show improvement. So, you know, and the PFTs are not overly sensitive to catch it. So in lieu of doing HRCTs every 6 months, I think we have to find another way to predict who's going to progress. You know, especially in light of the tocilizumab data where they caught all those people super early and it seemed to have the best effect. A lot of these have the better effect when you catch them. A lot of the trials just included people with early disease, like 5 or 7. So if you wait, you may have passed the chance. So if we can figure out who is going to develop it, we may be able to say, oh, you know what, you should get Rituxan. Like we don't just want to give everyone rituximab. So yeah, I do hope that's like a main goal.
Hi, Jana. Again, that was a really nice talk. Yeah, I think a lot of us have been interested in trying to understand, you know, what goes on in the skin, kind of puts a window into what's going on into the lungs. Based on what you've seen, what do you think is the interplay between the, you know, inflammatory mechanisms in the skin and how that reflects the lung or vice versa? I'd be curious if, based on what you're seeing, what you think is happening.
Yeah, so we've seen some signals that some like transcriptomic signatures that have actually been found in just skin data and in skin lung data. I don't think they line up perfectly. I think a lot of times the skin, from, you know, what I've experienced and what I've read, the skin will actually heal a little bit after the initial phase of scleroderma, but the interstitial lung disease will get worse. So that means that there's something different going on in the lungs. But one of the predictors, not like overly sensitive or specific, but one of the predictors is rapidly worsening skin predicting lung disease. So there must be something similar going on in the lung as far as the skin. But one of the big interests is like how we can correlate that skin to the lung. Like what is it exactly that is similar and what is different? Because it, you know, it's obviously part of the same process, but not exactly so. Yeah.
You elegantly showed us, Jana, the multiple therapeutic approaches have been used. Where at Yale are we in terms of our approaches, as far as you know, for people who have advancing interstitial lung disease? Are we going with myclophenolate? Are we using one of these other agents? And there are others in our audience who are working on this as well. So.
Yeah. So I'm going to answer from the perspective of a third-year fellow who has talked to a lot of the ILD doctors who do this a lot and has done it only a little bit. From what I understand, and please correct me if this is not correct, we are using myclophenolate as first line. A lot of times the rheumatologists will prescribe the rituximab I believe we are using tocilizumab occasionally, but not as much because of the data, because it was a secondary outcome and the fact that you have to catch people early. And then I do believe that we are using OFEV, but like I said, this is like, you know, there are people who could probably answer this better than I could, but I do believe that we are sort of following the guidelines.
Okay, I cannot answer that question, but my question for you is, there must, and unless I missed this, I could have missed this, there must be data on scleroderma lung signatures,
Yeah.
right? Mm-hmm. And have you compared what you find in the skin to the lung? Or have you just planned to do that, or have you looked at that? Anyone looked at that?
Yeah, there's not a lot, actually. A lot of people, I think part of the problem is it's very hard to get lung tissue. You know, it's either from explanted scleroderma, and then the controls are basically donors who were denied for some other reason. So it's very hard. But there have been some people that looked at it, and some of our data is overlapping and some of it is not. A lot of them have looked at the immune cells. A lot of them have looked at the immune cells, actually. Like there's been a lot of studies about like the immunity in the lung and the skin, but that's the ultimate goal, is to look at the lung and the skin. And because we can't lung biopsy everybody, and we can pretty much skin biopsy everybody, like find out what in the skin predicts the lung. Did that answer your question? Yeah.
My question is, do you think we obviously we've been talking about SSc-ILD, but do you think there's any correlate between what you're seeing in the skin and pulmonary hypertension associated with SSc? Yeah.
Yeah, that's a good question. Or are they two completely separate processes? And also, I will point out also just that pulmonary arterial hypertension, you can get pulmonary hypertension from the interstitial lung disease, which would be like a group 3. But whether or not like strict pulmonary arterial hypertension and scleroderma, are they connected? I mean, they're different. I think they are connected. And I'm sorry, I'm wobbling around because I haven't really thought about this. But like the endothelial damage is consistent in both. You know, that's one of the primary mechanisms for how this develops, is the endothelial damage. So I can only imagine that like maybe one pathway goes down the like pulmonary arterial hypertension route, and one goes down the ILD disrepaired like fibrosis and remodeling. But the endothelial like disturbance is probably the initial hit, and that sort of makes me think that there may be a similarity between the two. And people have both, but a lot of people just have one or the other. Yeah, that encompasses everything. You either have both, one or the other, or none.
Any other questions?
Great talk. And you know, you've really done a lot in the last year, and that, as you know, learning genomic analysis and transcriptomic analysis at the level you have, just really you made it look a lot easier than I'm sure that it was over the last year.
Thank you.
If I understand your cohort correctly, they all have skin disease, but they don't all have ILD. No. Or do they have no ILD?
They had unknown ILD. We had phenotypic data.
But they have DLCOs.
They have FVCs and DLCOs.
And lung function. Mm-hmm. And you've shown very nicely a correlation between your signature and their DLCO and their lung function. But getting at the question of progression, or which ones actually have ILD or progress, is there an opportunity here to go back to the authors, the people who published that, and say, do you have follow-up data on these patients so that you can actually get some correlate with your signature, or in your analysis, which ones actually progress? Because that would allow you to actually, you know, optimize, or I guess focus, hone your signature on patients that you could potentially treat early. Because I think we know with all of these lung diseases, not just ILD, but even in asthma, the name of the game is really prevention. Mm-hmm. That by the time we see the disease, you know, the horse is out of the barn, and it's very tough to slow down.
Yeah, no, I love that question. So I do think there is follow-up data. I haven't analyzed it yet, but all of these were taken at a baseline visit for 2 studies. So they definitely have longitudinal data on this. I just haven't looked at it yet because we pulled out the baseline. So I think it would be amazing to look at the cutaneous signature and how it performs over time, how it performs with mycophenolate, how it performs with, that study was imatinib, which has kind of like gone like this as far as like studies for scleroderma, lung disease, but like, see how they respond to imatinib, see how they respond to other things. I think that's definitely in the pipeline and something we want to do.
Very good. Well, so thank you so much for the great presentation. Thank you, everyone. Thank you to the applicants for sticking here with us and hearing the presentation. And we hope that you enjoyed one of our top meetings here at Yale PCCSM. All right. Have a good afternoon. Bye.